Hi, my name is Kaushal. I'm the Chair of Healthcare Policy and Research at Weill Cornell and New York Presbyterian Hospital. We are a department of 40 health data scientists, and I'd like to start by applauding the committee because I think that the question that was asked in this report is the single most important question in health policy today, which is how do we understand how to deliver better health care to high-need patients. Let me tell you just a little bit more about myself and then give you some of my reflections on the report. And I'll save some comments about additional data sources and some of the work that we've been doing for later on in the panel. My own work has focused on health IT and patient safety originally, with an increasing interest in building data infrastructures to support all types of research, particularly health policy research, with an ultimate goal of trying to improve the value of healthcare. My own research team right now is very much focused on what we call modifiable high-need patients or modifiable high utilizers. And I look forward to sharing some of our work with you. In terms of data infrastructures, there's been two initiatives that I've been very involved in. One is that I've recently become the PI of one of the Precision Medicine Initiative Healthcare Provider Organization grants, also known as All of Us. In these, across 8 centers across the US, we are now trying to enroll 1 million patients with biospecimens. And I would challenge us in future iterations of this work to think about biospecimen and genetic information and the importance of that in tailoring care, particularly for high-need patients. And then the second initiative is I have been the PI of one of 13 clinical data research networks across the US. These have been funded by PCORI, and they are collaborations that bring together clinical data. In our case, rich amounts of claims data. We have across New York City, 10 million patients with clinical data, about 100 million encounters. We also have Medicaid data, Medicare data, and 2 private health plans. And we have also chosen to incorporate social determinants of health. And I'll spend a little time later on talking about the importance of data, the importance of standardizing that data, and how that might inform a taxonomy 2.0, and what that might look like if we could roll it out more broadly. I would really like to congratulate the authors of this piece. It is one of the most thoughtful, elegant, comprehensive, yet practical pieces that I have seen. It was a very quick read, and I think that it was quick not because it was simple, but because it was presented so elegantly and so thoughtfully. So my first comment is kudos to the team here. The second is that this is a really beautiful example of team science. We talk a lot about team science, but in this report, you could hear the voices. Like Melinda, I heard your voice. I heard Ashisha's voice. I heard so many people's voices throughout this report, and you could tell that this wasn't just a pure exercise. It was a true labor of love, and there was very few. My sense was that there was very few a priori assumptions going into this work, which I think, Peter, you alluded to as well. I love the fact that there was empiric work included. I think that that's really important. I was also pleased to see that the patient perspective was included through the patient vignettes. I like the fact that there was a holistic look at high-need patients. It's too easy, I think, to be constrained to the health care issues, and here health outcomes were certainly included, but so were functional issues and social issues and behavioral factors. I think there's further pressure testing we can do and taxonomy improvement we can do, particularly through the patient lenses, but also through health system lenses and clinician lenses. I think that one thing that I would love to explore a little bit more in the next half hour or so is why segment patients versus stratifying patients. My answer to why this report segments is because the data source is claims data, and with claims data, it is, I think, the easiest to segment based on healthcare utilization. But I will share some of our own work, and in our work, we're actually doing cumulative risk scores, and I think you were sort of alluding a little bit to this as well in terms of clarity about, are we segmenting, are we stratifying, and what is most useful to our clinicians and health system leaders as they try to put these tools into actual practice. And then I would just applaud again the committee on not stopping with the taxonomy. I think it's really easy under the auspices of the National Academy of Medicine to stop with a pure taxonomy or the research piece of it, but to go further and to really try to target for given segments of patients, what are the healthcare models that are most effective, and what are the attributes of those care models, as well as the thoughtful exploration of health policy issues. I do agree that there's more we could do, there's more models we could look at, there's more we could incorporate in terms of the policy issues, but I felt like this report was one of the most compelling pieces that I have seen in a long time, and I hope it gets a tremendous amount of traction.